In fact, did you know that up to 1 in 5 or 1 in 6 of patients who have a knee replacement continue to report some moderate or even severe pain? Hi, my name is Jonathan Quell and I'm an orthopaedic surgeon specialising in hip and knee surgery. I'm going to spend the next few minutes talking to you about knee arthritis. Knee arthritis is a condition where the joint surface of the knee is gradually damaged and worn away. There's a variety of risk factors for this, and these include previous injuries to the ligaments and the cartilage, inflammatory conditions such as rheumatoid arthritis, previous knee surgery, and there are some rare causes as well. For instance, when the bone underneath the cartilage dies and the cartilage comes away. However, the majority of cases, it just comes from the wear and tear that you develop as you get older. There are some people who are overweight and those with a strong family history who might develop it earlier than others, but in general, people tend to develop it later in life, for instance, in their 7th, 8th, or even 9th decades. What are the symptoms that you might get with knee arthritis? The predominant symptoms that you get with knee arthritis are pain, but you can also get swelling and loss of function. The pain is typically felt all around the knee, but it may be present on one side or the other. It can wake you up at night and is often most present when you're doing activity, particularly going up and down stairs. In terms of swelling, this can often be felt just above the kneecap, but also around the rest of the knee, and sometimes you can get a cyst that sits at the back of the knee, often called a Baker's cyst. You may also notice that some deformity develops, so the knees can curve out, this is called being bow-legged, or bend in, it's also called being knock-kneed. What should I do if I'm worried about knee arthritis? Knee arthritis is a condition that often develops over years rather than days, and therefore in the first instance, the best thing you can do is stay active, take some painkillers when you need them, and lose weight if that's necessary. If the pain continues despite these measures, then you may need to see a physiotherapist or a doctor who can advise you about some of the painkillers that you might want to take, or send you for some investigations. If the symptoms persist, then coming to see an orthopaedic surgeon like me may be the appropriate thing. I would typically do an X-ray and examine you, and if I felt there was need for surgical intervention, I would advise this. How is knee arthritis treated? Knee arthritis is treated on a case-by-case basis. For some people, it's obviously important that we intervene and do some surgery straight away. But for others, often the best thing is to manage your symptoms without an operation. This can be a combination of doing the right kind of exercises, taking the right kind of painkillers, sometimes having a steroid injection or another type of injection. It can also mean doing some physiotherapy to try and strengthen the specific muscles around the knee to help you mobilize more effectively. If these all fail, then surgery may well be indicated. Unfortunately, often in knee arthritis, doing a simple operation like an arthroscopy where we put a camera inside the knee and take away any damaged tissue will not improve your symptoms significantly, and therefore bigger surgery is often required. If you're very young, then a joint replacement may not be the right idea for you because you need to have something that's robust and can last a long time. In these instances, an operation called an osteotomy, where we break and realign the bone to take the pressure off the damaged knee joint, may be appropriate. The final option is to consider joint replacement surgery. This is very effective at relieving pain and restoring function. My preference when I can is to always do a partial knee replacement where we just replace the damaged part of the knee. But that isn't always an option, and sometimes a total knee replacement is required. Unfortunately, not everyone is happy with their knee replacement. In fact, did you know that up to 1 in 5 or 1 in 6 of patients who have a knee replacement continue to report some moderate or even severe pain? Sometimes this can be because there's been a complication or a problem, but sometimes it can be just one of those things. I spend a lot of my time trying to solve some of these problems, either after the surgery or, even better, by improving the outcomes of the patients I'm operating on for the first time. Some of the things that I'm doing include the use of a specialist implant that allows me to align the knee more specifically to the anatomy that you have. This is called patient-specific alignment. It's got other names as well, such as functional alignment or kinematic alignment. The principle of this is that the knee in each individual is aligned slightly differently, often at an angle to the floor. By putting the knee replacement in exactly where your anatomy was before you got arthritis, would, in our experience, improve your outcome. I have to use specialist instruments and an implant to do this, but certainly in my experience, patients are happy and return to normal function at an earlier date. I also prefer doing partial knee replacements where I can, because the evidence supports a quicker recovery and a more normal feeling knee. The other work I've been doing is looking at enhanced recovery. This is the idea that if we can get you pain-free, mobilizing with crutches if necessary, as quick as possible, you can begin your rehab and hopefully have a much better outcome. The evidence would support that this is the case, and so I spend a lot of time working out how we can optimize pain relief for our patients afterwards, reduce swelling, and get you going sooner and better. When do I need a knee replacement? If you have significant pain and loss of function, particularly if it's waking up at night, then a knee replacement is often a good option for you at this point. However, I do take every precaution to treat each individual and their symptoms and their life circumstances into account before I make this kind of recommendation. How long do knee replacements last? Knee replacements last in excess of 20 years according to the National Joint Registry. Clearly, the younger you have it, the higher the chance is that it might fail in your lifetime. And so if you can delay your surgery, that is often the right thing to do. Some of the reasons that knee replacements might fail include an infection, which can happen early or late, wearing out of the implants, particularly the plastic that we put in between the femur and the tibia. And also the bone can soften, making the implant loose, or you can suffer a fracture around it. If any of these things do happen, then often revision surgery is something that we have to resort to. How is a knee replacement performed? A knee replacement is done under a general anaesthetic. We make an incision down the front of the knee after carefully preparing the skin, and we use saws and special instruments to prepare the bone to cement implants in place. We spend a long time trying to make sure that the knee replacement is suitable and well balanced within the knee so that you get the best function possible from it. We close the knee with sutures that are all dissolvable, and in a number of patients, you're able to go home on the same day because you're able to walk on your knee straight away. Typically, the first 2 to 4 weeks are hard. You've got a lot of pain, there's a lot of swelling, bruising, but after that, things do improve. By the time people come back and see me at 6 to 8 weeks, generally people are moving well, independently, or with just one stick. I would expect that patients continue to improve right out to a year, if not beyond. So this will not be the end of your recovery, but certainly you will begin to think that you're doing better than you were before the operation by this stage. How successful are knee replacements? The majority of people who have a knee replacement do really well. 80 to 85% report good relief of pain and restoration of function. Unfortunately, there are a proportion of patients who don't do well, and I spend a lot of my time trying to improve these patients' outcomes. Sometimes revision surgery is required, but we try and avoid this if we can, as often doing another operation will not solve the issue.